topic that we have chosen today is very, very relevant. And over the next 4 weeks, we'll cover different aspects of calcium problems and pathophysiology, including hypocalcemia, hypercalcemia, rickets, and renal tubular acidosis. Month-old boy with respiratory distress who also had hepatomegaly and cardiac failure was in fact admitted under the cardiac unit. So this child was admitted as cardiomyopathy in the cardiac unit with a very low ejection fraction. And at that point of time, when they evaluated further, they found that the child actually had prolonged QT interval and was found to have hypocalcemia. And then the referral was done to us, and what we found that this child actually had a vitamin D deficiency. And now we know how severe vitamin D deficiency can cause cardiomyopathy. Now, this was those early ages when this was not really easily available and was not really informed. So unfortunately, this child had to go on ventilator and a lot of other complications happen. But till date, also, we occasionally see patients with cardiomyopathy. So hypocalcemia is a significant cause of concern, and we need to have a proper evaluation, assessment, and management to identify in that regards. All of you can go and have a look at our website, learning.rosesociety.in, which has got a lot of information about pediatric endocrinology, including e-learning resources in the form of YouTube videos, our platform, which has got validated tools for assessment, as well as courses for fellowship programs and postgraduate programs, also courses, which are a lot of modules available. We routinely conduct grand rounds, the postgraduate lecture series, as well as specific rounds related to pediatric endocrinologists on a monthly basis. We have got publications which can be accessed both in an e-version as well as the hardcore version and the mobile application, which really allows evaluation and management of pediatric endocrine disorders very easily. So what I'm going to do today is that we'll talk a bit about pathophysiology to begin with, then we'll talk about criteria and etiology. And then from there, we'll talk about assessment, management, and finally, since this is directed more towards pediatricians and postgraduates, we'll also have some very practical questions which have been prepared in the form of OSCEs, as well as questions which will be highlighted. So hypocalcemia could be because of ionic deficiency, because of chelation due to hemolysis, tumor lysis, blood transfusion, or alkalosis, in which you will have classical clinical picture, and phosphorus may be high in that scenario. You may have decreased total calcium because of a vitamin D related cause, because of deficiency, inactivation, chronic kidney disease, or vitamin D dependent rickets type 1 and 2. Classically, you will have hypophosphatemia with rickets, while you may also have a PTH related cause because of hypoparathyroidism, pseudohypoparathyroidism, kidney abnormality, where you will have a high phosphorus and you will have calcification.
So it is a very common entity of the hypocalcemia, which is generally seen in the newborn units. And it is, as we all know, there is a physiological dip in the first 24 hours of life post-neonatal. And when there is an exaggeration of the physiological dip, it will result in the transient hypocalcemia. And see, what are the factors that can cause transient hypocalcemia? It can occur in the setting of birth asphyxia, which could cause high calcitonin level and high phosphorus level. Another cause, it can be seen in the setting of infant of diabetes mother, where there is a low magnesium levels and there is an impaired PTH axis. Now coming to the most common cause, that is the prematurity. As sir has already discussed that most of the calcium is transferred from the mother to the fetus, mostly in the 3rd trimester. And for the premature babies, they don't get enough time to fulfill their stores. So definitely they have very low stores of calcium in them. So it causes the transient hypocalcemia in them. And other factors could be they have immature PTH axis. And due to the low store, they have transient hypocalcemia. Now moving towards the hypomagnesemia, it is very important common cause of hypocalcemia because magnesium is very important and it is very essential for the PTH release and its action. As calcium acts on the calcium sensing receptor, the magnesium also acts on the same receptor. So when there is an excess or there is a high levels of magnesium in the blood, it will act on the calcium sensing receptor and it will further decrease the PTH level. And it will decrease the PTH release and it will cause the hypocalcemia. On the other hand, when there is a mild magnesium deficiency, it will inhibit the type 1 PTH receptor, and along with it, it will also impair the function of 1-alpha hydroxylase, which is present in the proximal convoluted tubule, which will further cause the hypocalcemia. But when there is a very low level of the magnesium, like in the severe hypomagnesemia, it causes defect in the calcium sensing receptor, and then it causes the decreased secretion of the PTH. So whether the magnesium level is high or whether it is low, in both the ways, it will impair the PTH secretion and it will cause the hypocalcemia. Magnesium levels and the PTH levels have an inverted J-shape association. The PTH levels are very low when when there is a severe magnesium deficiency. The PTH levels start rising when the magnesium level is around 0.6 millimole per liter. It will continue to rise and become stable till 1.2 millimole per liter. And after 1.2 millimole per liter, the PTH level will start falling down. So when there is a total body magnesium deficiency, definitely it will cause impaired PTH secretion instead of the normal serum magnesium. So we should always keep our ears and eyes open. In the case of hypocalcemia, always check out the magnesium levels, whether they are high or whether they are low. So moving towards the next cause, vitamin D related causes. As Dhwani has already mentioned, that with most of the pediatrician or the PG students, this is the most common cause that they are going to face, the vitamin D related causes of hypocalcemia. And what happens here? The low exposure of sunlight. As we all know, sunlight is very essential for the conversion of cholecalciferol to the vitamin D. So when the areas where there is low sunlight, with the people who are not exposed to sunlight, they are more prone to have vitamin D deficiency related hypocalcemia. Another cause could be like liver disease, where there is impaired action of the 25-hydroxylase. Another could be like inactivation by the use of antiepileptics like the phenytoin, carbamazepine. In the CKD and the vitamin D dependent rickets type 1, where there is an impaired activity of the 1-alpha hydroxylase, it will also lead to the hypocalcemia. And the last one is the resistant to the action of cure. That is the vitamin D dependent rickets type 2. So in all the cases, we'll get low phosphorus, and the presentation will be like around after 3 to 6 weeks. The vitamin D deficiency will not present like in the very neonate periods. They will only occur after the period of 3 to 6 weeks. And this is very important point, like when there is a chronic vitamin D deficiency, it will lead to PTH resistance. And what happened in that? See, in the PTH resistance, the PTH levels are good, but the action is impaired. So they will present with hypocalcemia, high phosphorus level, and high PTH level. So in any neonate or infant, if you are having like hypocalcemia along with high phosphorus levels and high PTH level, you should not conclude to that this is PHP, which is pseudohypoparathyroidism, because PHP does not occur in a neonate baby and it never present with a frank hypocalcemia in a very early age. So if this presentation comes to you, always think that this PTH resistance could be due to chronic vitamin D deficiency, and always check the vitamin D levels in that case. So hypoparathyroidism, in which there is deficiency of parathyroid hormone. And what does parathyroid hormone do? As sir has discussed already, that the role of parathyroid is to bring out the calcium from the bones and increase the calcium level. So when there is a PTH levels are low, the calcium will not come out from the bone. It will cause hypocalcemia. The PTH is also responsible for the calcium absorption, that 5% calcium absorption from the DCT. So it will not able to absorb the calcium. It will cause the hypercalciuria. And the PTH is also responsible for the phosphate excretion. So in the PTH, low PTH levels, there will be hypocalcemia along with the high phosphoric levels with the low PTH levels. And one thing more, the PTH is also responsible for increasing the activity of 1-alpha hydroxylase. So when there is a low PTH level, the level of calcitriol will also be low, which makes the intestine more permeable to the calcium. So it will also decrease the absorption of calcium in the hypoparathyroidism. So the patient will have high phosphorus, inappropriately low PTH, and definitely they're present after 3 days, not in the very early period like after 1 to 3 days. So always keep in mind that if the patient is present after 3 days, there could be like, you should keep that it could be like hypoparathyroidism could be the cause of hypocalcemia. So moving towards the next, calcium sensing receptor defect is a very interesting cause of, I would say, of hypocalcemia. As the work of calcium sensing receptor is to regulate the calcium level in the blood. And they are present in the parafollicular C cells of the thyroid, in the this parathyroid gland, and also in the proximal tubules of the kidney to absorb the calcium. But when there is an activating mutation of the calcium sensing receptor, what the body sense like, yeah, I have a lot of calcium inside me and I want to excrete it. I want to get rid of this calcium, and it decreases the PTH level and increases the calcium excretion. So it will decrease the PTH, it will increase the calcitonin, and it will present with hypocalcemia and hypercalciuria. And they will be high phosphorus. Now, coming to the 22 deletion syndrome, this was mentioned in the first case by the sir. It is caused by the defect in the gene TBX1, and it involves many systems like thymus, anatomical defects of the face, anatomical defect of the outflow of the heart. And what does it happen? In 22 deletion syndrome, there is a contiguous gene deletion. And what does it mean? It means that the presentation will be variable, and the presentation will depend on how many genes are gone or deleted. So there will be variable presentation of this 22 deletion syndrome. And it has many names. It is known as DiGeorge syndrome, as we all know, velocardiofacial defect, monotruncal anomaly facial. Now coming to the DiGeorge. How does the DiGeorge syndrome present? And recently we have managed this DiGeorge syndrome in our hospital. The patient classically present with the facial features of cleft lip and the cleft palate, compressed facies, and the low-set ears. And the patient will have recurrent chest infection due to thymic aplasia. And there is a very important point I want to highlight here, that thymic aplasia is very non-specific feature of DiGeorge syndrome. Like if you're finding absent thymus in the X-ray, chest X-ray, you should not conclude to the diagnosis of DiGeorge syndrome, because on the other hand, if there is a thymus aplasia, you should at least suspect. You can suspect, because this is a very non-specific feature of the DiGeorge syndrome. And there is low T cell count. The cardiac features all involve the conotruncal defect, and it includes like tetralogy of Fallot, VSD, vascular ring interrupted arch, truncus arteriosus, and it presents with hypocalcemia, which can be variable, which can have variable presentation. It can present either in the infancy or in the puberty also. And this is very important, like the hypocalcemia in the DiGeorge is precipitated, is exaggerated by the use of furosemide. Because what does furosemide do? It causes hypocalciuria. It excretes the calcium from the body, so it will excrete the hypocalcemia. So never use furosemide in the patients of DiGeorge syndrome. And it has other associated features like anal or esophageal atresia, dysplastic kidney, and ocular malformations. Now coming to the infiltrative disorders. Among the infiltrative disorders, autoimmune is the most common one. And within the autoimmune, APS1, which is autoimmune polyclanular syndrome type 1, is the most common. And it is caused by the defect in the AIR gene. Others are APS2, which involves mostly the adrenal. Also, hemochromatosis is one of the infiltrative disorder, which could be caused by the repeated transfusion in the thalassemia patients or the primary iron overload. It presents with the pigmentation and gonadal failure. Also in the Wilson's disease, which present with neurological psychiatric features, and they have high urinary copper. Now coming to the APS1, the first clinical manifestation that the patient of APS1 will have is the mucocutaneous candidiasis. It presents with the age group of 2 to 5 years, and it is universal. It is always the first manifestation. Now coming to the preceded by the mucocutaneous manifestation, they'll have hypoparathyroidism, which occurs in the age group of 5 to 7 years, and hypoparathyroidism is the first endocrine manifestation of APS1. Later on, the adrenal glands are also involved around the age group of 10 to 20 years, and they will present as primary adrenal insufficiency. The they could also have transaminitis, urticaria with fever. In some patients, urticaria with fever could also be the first clinical manifestation. Rarely can have GI symptoms, constipation, diarrhea, keratoconjunctivitis, pneumonitis, and Cochrane-like syndrome. Okay, now coming to the PTH signaling defects. These are very interesting defects. If we really go into the etiology of it, the type 1 PTH receptor. Let's talk about the PTH-RP first. The PTH-related peptide. It is the most common or the most important paracrine hormone which is required for the chondrocyte growth. Okay, so for the fetal to develop, for the fetus to grow, PTH-RP is required, and both PTH-RP and the parent hormone acts on the same receptor, that is the type 1 PTH receptor. Okay, so if the patient is having hypoparathyroidism, the hypocalcemia in those patients will not be that severe. The fetus can grow without PTH deficiency because they will get the calcium from the mother. But in case where there is a PTH-RP problem, or in the conditions where there is defect in the receptor on which the PTH-RP works, in that condition, the fetus will not able to grow. There will be intrauterine growth retardation, and this intrauterine growth retardation is also known as Bloom-Strand chondrodysplasia. The chondrocyte won't grow; they will be dysplastic chondrocytes. Okay. Now, coming to the PHP, what is PHP? PHP is a pseudohypoparathyroidism, and the PTH acts on the PTH receptor, and it also via the alpha subunit of the G protein, it starts its work. So when there is defect in the alpha subunit of the G protein, it will cause PHP 1A and 1B. I'll describe what is 1A and 1B in the following slides. Let's see what is the classification is. And when there is a defect in the linkage between the PTH receptor and the alpha subunit, it will cause PHP 1 type C. And when there is a problem after the cyclic AMP production, then it will cause PHP type 2. And there is another entity known as acrodysostoses type 1, which is caused by the defect in protein kinase A. And acrodysostoses 2 is caused by the defect in the protein phosphodiesterase. So coming to the what is PHP type 1A? See, there are so many tissues in our body. Every tissue has a genetic expression, and each gene is inherited from either by the mother or the father. Okay, so in the PHP type 1A, when this defect is present in the mother and that defect is inherited from the mother, that will cause PHP type 1A. And as there is a defect in the alpha subunit, there will be no cyclic AMP formation and there will be no phosphorus response. And the patient will present with a manifestation of skeletal dysplasias like Albright hereditary osteodystrophy, which is characterized by round facies, brachymetacarpia, obesity, ectopic calcification. It could be intracranial or subcutaneous. This is the picture showing the brachymetacarpia. When you will ask the patient to this clench your fingers, and you will see the depression between the third and the fourth metacarpal, that is the brachymetacarpia. Intracranial calcification is also the manifestation of PHP type 1A, and this black dot in this is sole is the subcutaneous calcification. And there is also resistance to other hormone which presents like obesity, high TSH with normal T4, pubertal delay, which is commonly seen in girls, and the growth failure. But there will be no hypocalciuria. Let me explain one thing here. If we talk about the calcium absorption, the distal part where the 5% of the calcium is absorbed, it has genetic expressions, both controlled by the mother and the father. And if there is a genetic defect from the mother, the normal father gene will take care of the absorption of the calcium. That's why there is no hypocalciuria in the PHP type 1A. Now coming to how PHP type 1A is different from PPHP, that is Psuedohypoparathyroidism. As I've already told that PHP type 1A is caused by inheriting the defect from the mother. On the other hand, PPHP is caused by inheriting the defect from the father. And type 1A will manifest like hypocalcemia. They will have bony disease, which is found in a cluster and known as AHO, that is Albright hereditary osteodystrophy. And while on the other hand, the pseudohypoparathyroidism will only have bony manifestation. They will only have AHO phenotype, and they will have normal calcium. As I already told you that the calcium absorption is controlled by both mother and the father. So if one gene is affected, the mother gene will take care of the calcium in this PPHP. So they will have normal calcium and they will only present with bony manifestations in the form of AHO. Now, if I summarize all the PHP in one table, all PHP will have low calcium except for the PPHP, that is pseudohypoparathyroidism. All PHP will have HO phenotype except for the type 1B and type 2. All will have low urinary calcium, low cyclic AMP except for the type 2 and PHP. Hormonal resistance to the other hormones like TSH, FSH, and GnRH will be seen in type 1A and type 1C, but in type 1B and PPHP, there will be no hormonal resistance. So, and I have already told you, like, pseudohypoparathyroidism also presents like chronic vitamin D deficiency. So when there is a hypocalcemia, high PTH level and high phosphate in the older age group, you should always, and when there is a age of phenotype, that is the round face cheese obesity, you should always keep in mind that it could be due to PHP.
Go and have a look at our website, and there are a lot of resources available, the courses which are available, as well as the books and the mobile application.